We will learn about the adrenoceptor antagonist drugs, or these drugs are also called as sympatholytic drugs, which means that they will block or antagonize the effect of adrenoceptors or adrenergic receptors. Catecholamines, they play a major role in many physiological and pathological responses, and the drugs that block their receptors therefore have a very important effect, some of which are of great clinical value. And these effects, they vary dramatically according to the drug selectivity for alpha and beta receptors. So the mechanism of action, we have to recall the mechanism by which the norepinephrine or epinephrine or dopamine, all these adrenergic catecholamines or adrenergic neurotransmitters, they have their effect. I have also discussed this mechanism in my previous video. So the process, that starts from the tyrosine. Tyrosine is a amino acid that is converted into dopa, which is an intermediate compound. This dopa is converted into dopamine. Dopamine is also a catecholamine. It is also a neurotransmitter of the adrenergic receptors. And this dopamine, it is converted into norepinephrine. This norepinephrine is the vesicle of norepinephrine. It fuses with the membrane of the neurotransmitter and is thus released outside of the cell into the junction. Now we have these postsynaptic cells, and these postsynaptic cell membranes, they have these receptors. So this is the this blue line. This is the cell membrane of a postsynaptic cell, and this membrane has all these adrenoceptors, which are manifested in this yellow shade. And what actually happens is that this norepinephrine, it binds to these receptors, and these receptors are activated, and then they produce the effects of sympathetic nervous system. However, when these drugs, the drugs which we are talking about, they are the antagonist. They are the adrenoceptor antagonist, or they are the sympatholytic drugs. So they have to they interact with these receptors and they block the effects of sympathetic nervous system. So these drugs, they will bind to these receptors and they will block the effect. They will inhibit these receptors, and the effects that are usually mediated by sympathetic nervous system, these all effects are blocked or reversed. So we can classify these drugs based on their manner of reversibility or irreversibility. There are some reversible antagonists, and then there are some irreversible antagonists. We have two classes. I will give few examples of both these classes. In the irreversible, we have a drug called as phentolamine. This drug is used in the treatment of pheochromocytoma, and we have a drug pyrazosine, which is used in the treatment of BPH, benign prostrate hyperplasia. Both these drugs, they reversibly bind with these receptors, and the effects of these drugs are reversed with an increased activity of the agonist. However, there is a drug which is called as phenoxybenzamine. This drug binds with the receptors irreversibly. It forms a very reactive ethylene ammonium intermediate which covalently binds to the receptors, and the blockade is usually irreversible. Now, the duration of action of any reversible antagonist, it is largely dependent on the half-life. It depends on the half-life of the drug, which will decide the duration of action and the rate at which it dissipates from its receptor. The shorter the half-life of the drug in the body, the less time it takes for the effect of the drug to dissipate. In contrast, the effect of irreversible antagonists, it persists long after the drug has even been cleared from the plasma. So the effects of phenoxybenzamine, they will even if the drug has been cleared from the circulation, the effects, they will stay in the body for a very longer time because it irreversibly binds with the receptor. It forms a covalent bond with the receptor. So this was a bit about the mechanism of action. Now we will move towards the pharmacological effects of the adrenergic antagonist. And first, we will discuss the alpha receptor antagonist. As we know that there are two kinds of receptors, alpha 1 and beta receptors, alpha 1, alpha 2. And we have beta 1, we have beta 2, and we have beta 3. Three kinds of receptors. We also, in the sympathetic, we also have dopamine receptors, but we will discuss those receptors separately. Now, in this video, we will discuss the alpha and the beta receptors. First, we will go towards the alpha receptors. So here's a classification. In the alpha receptor antagonist, we have phenoxybenzamine, we have phentolamine. Both of these drugs, they are used in the treatment of pheochromocytoma. The prazosin, doxazosin, tamsulosin, and alfuzosin, they are used in the treatment of BPH. Cytodosin is also used in the treatment of BPH. The euhimbin it was previously used in the treatment of erectile dysfunction, but now it has been replaced by a better form of drugs. We have labetalol, which is used in the treatment of hypertension. So here we have the beta receptor antagonists, in which we have non-selective, these are selective, and these are partial agonists. We will discuss the beta receptor antagonist in detail later on. So let's move towards the alpha antagonist, organ system effects, and the clinical uses of these drugs. We will start the effects from cardiovascular. In the cardiovascular system, the major effect of the blockade of adrenergic agonist causes a lowering of the peripheral vascular resistance and blood pressure. So two major effects that you need to remember is that they decreases the peripheral vascular resistance, and this action is mediated by the alpha receptor blockade, alpha 1 receptor blockade. As alpha 1 receptor is usually uh, used to induce the vasoconstriction in the smooth muscles of the vessel. So when this receptor is blocked, the effect we see is usually decrease in the peripheral vascular resistance. So this is the first effect that we need to remember in the cardiovascular system. And the second thing it does is that it reduces the blood pressure. The blood pressure is reduced, and this effect is also mediated by the blockade of the alpha receptors. So we have a number of clinical applications in terms of cardiovascular system. Number one is the hypertensive emergency. So the adrenoceptor antagonist drugs, they have limited application in the management of hypertensive emergencies, but there is one drug which is called as labetalol. This drug is a non-selective adrenergic blockade, and it blocks alpha as well as beta receptors. In alpha, it only blocks alpha 1 receptor. This drug has two isomers, an R isomer and an S isomer. The SR isomer that is used to that blocks the alpha 1 receptors, and it produces an antihypertensive effect. In the theory, they are most useful when the blood pressure reflects excess circulating concentrations of alpha agonists, for example, in the state of pheochromocytoma, or overdosage of sympathomimetic drugs, or clonidine withdrawal. So all these drugs, they're generally preferable since considerable experience is necessary to use alpha receptor antagonist drugs safely in these settings. So all the hypertensive emergencies that are due to an increased concentration of alpha agonist, they can be treated very successfully with the use of this drug, labetalol. So some members of alpha adrenergic antagonist, which includes parazosin, doxazosin, and terazosin. All these drugs are used in the treatment of hypertension. Of course, they're not the first line therapy in the management of hypertension. They are always an add-on, and they're always used in combination with other antihypertensive drugs to treat the hypertension, and they're not recommended as a monotherapy, but these drugs, they are used in the treatment of chronic hypertension. And it is the adverse effect that is most commonly seen with these drugs is orthostatic hypotension and tachycardia. Both these effects are often seen with the usage of these drugs. The orthostatic hypotension is usually mediated by the vasodilation, and the tachycardia is usually a reflex response by the baroreceptors. The prazosin, it is a selective for alpha 1 receptors, and it is almost thousandfold less potent at the alpha 2 receptor. So it has a very little activity for alpha 2 receptors, and it relaxes both arterial and venous smooth muscles, and it also relaxes the smooth muscles in the prostate. That is why these drugs are also used in the treatment of BPH. The terazosin is also an alpha 1 selective antagonist, and it is also used in the treatment of hypertension. It is also used in the treatment of benign prostrate hyperplasia. And the doxazosin, it is also alpha 1 agonist, no effect on the alpha 2 receptors, and it has the longest among all these drugs. The doxazosin, it has the longest half life of around 22 hours. The prazosin is the most short acting, it has a half life of around 3 hours, whereas the terazosin, it has a half life of around 9 to 12 hours. So it comes in between these drugs. Both these drugs, we need to remember that all these drugs, they are always an add-on therapy, and they're not the first line treatment of hypertension. There is a drug which is called as euhimbine, which is an alpha 2 agonist, and it has been used in the past for the treatment of orthostatic hypertension. Orthostatic hypertension occurs when the body of the patient, when the vessels in the body of the patient, they are very dilated, and due to this dilation, the blood, it pulls into the peripheries, and as a response, the patient suffer orthostatic hypertension. It means that when the patient is sitting or when the patient is laying, their pressures are fine, but when these patients, they get up or they stand, their pressure drops down. So euhimbine, it is a drug that was previously used to treat orthostatic hypertension, but now it is not very commonly used nowadays because of an adverse effect profile. The alpha adrenergic antagonists, they also have a role in peripheral vascular diseases, and occasionally in the setting of Raynaud phenomena. In the Raynaud phenomena, what actually happens is that the peripheral vessels, they have become so narrowed in the extremities that it restricts the blood flow, and this usually occurs in the fingers and the toes. So in this setting, we use phenoxybenzamine. We have already discussed that phenoxybenzamine, it is in alpha 1 and alpha 2. It antagonizes both these receptors, and we also use prazosin in this setting. Along with these, we also use calcium channel blockers to treat the Raynaud's phenomena. It is also used in the treatment of conditions that involves excessive reversible vasospasms in the peripheral circulation. Conditions like these, they also benefit from the prazosin or phenoxybenzamine. Now, the most important use of these drugs, it is in the setting of urinary obstruction. These drugs are most widely used for the treatment of urinary obstruction, and in these we use the doxazosin class, the same class that we discussed in the antihypertensive group, we have prazosin, we have doxazosin, and we have terazosin. Apart from these, there's another drug, tamsulosin, which is very selective for alpha 2A receptors, which are present in the prostate. Tamsulosin, it binds with these drugs and causes the relaxation of these smooth muscles. And as a result, the vasodilation in the prostate occurs, and it is very important effect in the setting of BPH, which is benign prostrate hyperplasia. So there are few other drugs which are not very commonly used, but we should know the names of these drugs and we should know what they do. There is a drug which is called as endoramine, and there is a drug called as urapidol. Both these drugs are also used in the setting of benign prostate hyperplasia. We have already discussed the pyridoxine class, and in the tamsulosin, we need to remember that it is a 2A selective class. It has a greater affinity for 2A. It has a half-life of around 9 to 15 hours. The adverse effects of all these drugs are somehow common, that they will cause an increase in the they will cause an increase in the heart rate. Tachycardia will be seen in the patients who are having these drugs, and the drug and orthostatic hypertension is very common in the patients who are using these drugs, and especially these drugs are usually used in the geriatric population. So orthostatic hypertension is a troublesome side effect or adverse effect that we often see with the use of these drugs. These drugs, they also have a role. They were previously used to treat erectile dysfunction. Now, these drugs, they have been largely replaced by sildenafil and other phosphodiesterase inhibitors. But previously, the drug euhimbine, it was used for the treatment of erectile dysfunction. It is an alpha 2 agonist, and phentolamine was often used in combination with a muscle relaxant, papaverine, and this combination, it was injected directly into the penis and was used for the treatment of erectile dysfunction. Long-term administration of these drugs may result in the fibrotic changes, which is a very troublesome response. So now these drugs, they have been largely replaced by the phosphodiesterase inhibitors because of the adverse effect profile. Now, pheochromocytoma, these drugs, adrenergic antagonists, they are used in the treatment of pheochromocytoma. Pheochromocytoma is a condition in which a tumor is formed in the adrenal medulla or sympathetic ganglionic cells. And as we can see in this diagram, these adrenal glands that lie on top of the kidneys, a tumor is formed in these adrenal glands, and this tumor, it releases an excessive amount of norepinephrine and epinephrine in the body, and both of these catecholamines, they causes an excessive sympathetic drive in the body. So we need a drug that are used to oppose the effect of excessive sympathetic drive. So in this regard, we use phenoxybenzamine and phentolamine. Both these drugs, they are used and they are the mainstay of therapy in the treatment of pheochromocytoma. The main clinical use of phenoxybenzamine is in the management of pheochromocytoma. Patients have many symptoms and signs of catecholamine excess in the setting of pheochromocytoma, including sustained hypertension, headaches, palpitations, and increased sweating. Release of stored catecholamines from pheochromocytoma may occur in response to physical pressure, So when it occurs during operative manipulation, we use a drug nitroprusside, which is a vasodilator. It is a preferred drug, and usually surgery is a mainstay of therapy in the setting of pheochromocytoma. But preoperatively, sometimes we use alpha receptor antagonists, and they are most useful in the preoperative management of the patients. They control the hypertension, they reverse the chronic changes that result from excessive catecholamine secretion, such as volume extraction or symptoms that are or headaches or any other symptoms of catecholamine excess in the body. Some physicians they use the phenoxybenzamine 1 to 3 weeks before the surgery. Along with alpha blockade, beta blockade is also necessary for the treatment of pheochromocytoma. So phenoxybenzamine, it binds to the alpha receptors, alpha 1 and alpha 2 both receptors. It has a very long half-life, as we have already discussed. It has a half-life of 14 to 48 hours. Very long half-life. It causes the irreversible blockade. It is selective for somewhat selective for alpha 1, but it also has an effect on alpha 2 receptors. And it is well absorbed after the oral administration. It is given in the oral form in the dose of 10 milligram per day, and doses of less than 100 milligram per day is usually sufficient to achieve adequate alpha blockade. Likewise, the phentolamine, it is a comparative antagonist at the alpha 1 and alpha 2 receptors, and it reduces the peripheral resistance by the blockade of alpha 1 receptors and possibly alpha 2 receptors on the smooth muscles. The adverse effect of phentolamine are tachycardia or arrhythmia or MI, and these adverse effects are very dangerous in the setting of already having and the patients already having pheochromocytoma. So this was all about the alpha receptor antagonist.